Hi, everybody. I'm Kelly Puente with the Long Beach Post, and we're here today to talk about a really important subject that's been in the news that's affecting Long Beach, LA County, California, and really we're seeing all across the country. And it's the racial disparities in the COVID vaccine rollout. We're seeing that issues, some concerns that the vaccine isn't reaching the hardest hit communities and the people that need it the most. And I have some very special guests with me today to talk about this issue that have been right out on the front line talking about this. And we have Professor Dr. Alex Norman, who's a professor emeritus at UCLA in public policy, and also the founder of the former Rethinking Greater Long Beach. And Alex has done some amazing work looking at life span disparities and zip codes and working on health inequities in Long Beach. So thank you for joining us. And we also have Laura Som, who is a founder of the May Center, and Laura's been a longtime activist in the Cambodian community here in Long Beach. And we also have Mark Coleman, who's a longtime civil rights lawyer in Long Beach. So thank you guys for joining us. Appreciate it.
Thank you, Kelly, for having us.
And wanted to start out talking about, we have a headline today just in our website, and it was LA County looking at the racial disparity in the vaccine rollout, especially in the Black community. In our story today from LA County, just 3% of Black residents in LA County have gotten the vaccine. In Long Beach, it's a little bit higher, but we're still seeing a huge disparity for Black residents getting the vaccine compared to wealthier white residents on the east side of Long Beach. And just looking at why that is. So I know Professor Norman, you've been working on this and inequities in communities of Long Beach for a long time. What's your take on this and what you see are some of the challenges here?
Well, I'm not surprised, really, because if you look historically at how science has treated Black people in this country, it's used us for experimentation. And one of the things that really is affecting the whole acceptance of vaccine has to do with the Tuskegee studies, in which the government scientists deliberately withheld penicillin from Black men who were infected with syphilis in order to see how the course of syphilis would run. So they used these people as guinea pigs. And this went on from 1932 until 1970s, when an organization in health, the National Health Legal Program, filed suit against the government and stopped the experiment. So even though that happened a long time ago, the stories for that permeated throughout the rest of the years. And so you can talk to somebody in Long Beach now, and they'll cite that area, that study, as a reason for their reluctance to accept the vaccine. Now you couple that with the fact that there's a lack of education in the Black community around health issues, and that when you look at the risk factors involving poor health, we as African Americans are really at the top. The study that Lydia Holly and I did on the state of Black Long Beach in 2013 identified health as one of the major issues around which Black people should come together because of the issue of obesity, of diabetes, of high blood pressure. So you couple the historical rumors that maybe this might be another experimentation, the fact that you don't have that many African-American health workers who are administering the vaccine because we don't trust white people, and especially white scientists. It's not accessible. So we need to roll out into Black areas with Black medical workers.
It's shown that it's predominantly too, it's younger Black men too that are dying of COVID at higher rates than almost any other race. And how does just systemic racism play into health issues for the Black community?
Well, in public health, there's something called allostasis. That is where the as you age, you end up with your coping mechanisms using all of the resources that you have. So the more resilient you are, the more you use your coping mechanism, the more likely you are to reach a point of allostasis. And that's where you're just not able to cope anymore. And so you're susceptible to a lot of things, stroke, heart attacks, you name it.
Your body's in like fight or flight mode, basically, just
Right.
constantly.
And what happens with the African Americans is that we are constantly coping. And as one of Cal State professors, Amber Johnson says, resilience is killing us. The more resilient we are, the more we have to use our coping mechanisms, the more we're using all of the internal capacity for dealing with issues. We get to a point where we've used up all of our resources, so we're dying earlier. We're getting heart attacks earlier. We're getting lung cancer earlier. And so in a sense, our resilience is both an asset, but it's also working against us because society has a constant pressure of discrimination, of systemic racism. And so we're constantly coping. And it's that constant coping that reaches the point of allostasis so quickly that then all of these, we become immune, we become susceptible to the other things that kill us, heart attack, stroke.
Interesting. And with the issue of PTSD and the Black community suffering with that, with racism, you could say, and we also see that in a lot of ways with the Cambodian community, and that working, and what they've had to deal with the genocide in Cambodia. Laura, can you talk a little bit about just how some of the health issues they've suffered over the years, and then what we're seeing as far as COVID? And Long Beach, by the way, has probably, is it the largest Cambodian community in California? It's next to Lowell, Massachusetts. I think it was Long Beach and randomly Lowell, Massachusetts as like the two cities, the largest Cambodian community. I think we have about 15,000 Cambodians here in Long Beach, would you say?
We think we have about 15,000, but we are heavily undercounted just because of our PTSD. And so Cambodian people immigrated to the city of Long Beach starting 1975 up to 1992. That's when I came as a former refugee. We have gone through extreme violence, tortures, PTSD, constantly living in fight and flight mode. 40 years later, a lot of the first generation who've experienced a genocide are seniors right now. And so every group has their unique challenges. And for us, it's compounded. And so a lot of the survivors are farmers, uneducated, because during the genocide, the purpose was to kill off educated people. And so when you're talking about pandemic, when you're talking about health issues, and you're talking about the vaccines, these people have to take our words for it. Well, what is science? What is virus? What is vaccine? And so the outreach is very difficult, let alone, the pre-existing health conditions is one thing. Poverty is another. Lack of education is another barrier for us. Language, lack of integration into a larger stream. And even so, the outreach into our community is almost non-existent, especially for the vaccine rolled out. And so it was only last Tuesday that I realized that there was a task force for the vaccine rolled out. And I looked through the rosters, and the city the health department has been meeting for a whole month, and there's no Cambodian organizations on there. None.
I'm surprised at that, one of the largest, groups in the city, and then not having a representation. That's surprising to me.
And so my community was scrambling for the last 2-3 weeks. Leaders of CBOs, faith-based, even Khmer TV, which is a social media that a lot of our elders have access to. They actually, contact me and say, Laura, what is going on with the vaccine? How do we have access to it? And so when we look at the process that the city rolled out, it really created this inequity against our community. One, we don't have data that separate Asians or Cambodians under Asians. let alone that we didn't have any Cambodian organization to speak up for us. And then there's no outreach into our community in terms of contacting the CBOs and say, hey, you guys are the trusted partners. We really need your help in this. And then more than that, I discovered that the only Cambodian clinic, FQHC, which is a qualified, it's a federally qualified health clinic that's supposedly supposed to get the vaccines, didn't get the vaccines for the seniors. And so we have so many issues right now.
Is there a reason why they didn't get the vaccine that you're finding out, or?
I'm still speaking to the health department and I'm asking them, well, do you know this FQHC, Cambodian FQHC exists? They didn't. And so I contacted the CEO and say, would you join this task force? Because it's very important for the city to establish that kind of relationship with a very important clinic that's the only Cambodian FQHC in the city of Long Beach. And so she's now part of the committee and she still hasn't received the vaccine for the seniors.
Wow. And Dick, can you explain a little bit why you feel it's important for Long Beach to differentiate Asian, Cambodian Asian when it's reporting COVID rates and vaccine rates in Long Beach? And have you spoken with the city about doing this?
I have, after they invited me into the subcommittee task force, I'm starting to tell them different processes that will work best for the Cambodian community. And so we're very unique from other Asian communities. For example, with the Chinese community, they have a better coping skill, resiliency, better integration to American society than Cambodian survivors who just escaped the genocide 40 years ago. And those seniors are trapped in PTSD, can't speak English, can't use technology, but they're relied upon a one-point access to put the appointments for the vaccines. And even so, when we as community organizers help them put these appointment requests, the city only have one staff that will call them back. For the whole city of Long Beach, there's only one staff. And so a lot of the seniors saying, I haven't received any calls. What is going on? And so that's some of the problems they're facing right now.
So, but the city is moving forward now and working with working with community groups and doing some mobile outreach for vaccine. On Saturday, they did on the west side of Long Beach, a mobile center where they had 500 vaccines for mostly Spanish speakers. And then I believe they are going to do an outreach, do a mobile center in Cambodia Town.
Yes,
soon, or
ironing out the process and the details. And it's supposedly they have 200 vaccines for the Cambodian community, which is very limited. And I know, the vaccine themselves is limited for the city, if not for the nation as a whole. But we're questioning, why is one community getting 500 vaccines versus the Cambodian community is getting only 200? And more importantly, the process itself has to be refined. I mean, they still have to go through the appointment process, going through the website, get their appointment through. Why couldn't someone walk up to a mobile clinic and say, hey, I'm 70 years old and I just heard this mobile clinic is here. Can I get my vaccine today? They would be turned away because there's no appointment for their name. More importantly, I've asked, how often will this clinic come to our community? And no one could give me that answer. And so if it's a one-time thing, it wouldn't solve the problem.
Yeah, so you haven't been able to get an answer if it's going to be multiple visits. And so right now you've just been promised about 200 vaccines really for that seems like not enough, especially obviously in a vaccine shortage right now, but that must be frustrating for you. What's been the feedback in the community with this?
It has been frustrating for all of us. For a lot of the CBOs, there's a lack of funding for us to even have staff coordinate all these things. For example, on Tuesday, the city talked about the 5 organizations that got funding to do the COVID education. But when I asked one of the lead organizer, the United Cambodian Community, Susanna, she said, well, the Cambodian zip code was excluded from that grant. So the larger organizations couldn't apply for the grant. And so not only our organization, Cambodian organizations are not getting the funding, the vaccines are not coming in, and we don't have the data that is separated for the Cambodian people. And so I'm speaking to the doctors, I'm speaking to different clinics, I'm speaking to the CBOs, and here we are, don't know what's happening to our community. And the seniors, the residents are calling us and saying, what happened to my appointments? I haven't heard, it's been 2-3 weeks.
Wow, there's so many challenges here, just the layers of mistrust in city government to just vaccine shortage to access for people in hard hit areas. You've talked about some of the solutions we've had here. We could have, what would you see? What are some of the solutions you think of, some ways we could better reach these communities and what you think the city could be doing?
Well, first of all, they need to generate the data so we know regionally in the zip codes or in the council districts where the vaccines are being given to the Cambodian people and where they aren't. So that's the first thing, is we need data. Second, they need to involve the community-based organizations, which started after Tuesday when we raised a fuss at the special city council meeting about the lack of more than one door to get the vaccinations. So one issue for the rollout has been the high level of technical expertise and language skill that you need in order to access an appointment. We have a one-door policy. I mean, there's only one way to get a vaccination. Places like Kedron Hospital, for example, in South Los Angeles, they figured out, let's just have a walk-up line and we'll have people go out and work with those people, sign them up, fill out the paperwork, record it on the computer later, and get them vaccinated. So
the city could do multiple routes instead of just the one VaxLB call. Yeah.
Yeah. So I don't know how the Silverado site worked in terms of people signing up who walked up or who didn't use the computers.
I believe it was on, they were on a wait list through VaxLB, and the city specifically targeted Spanish speakers age 65 and over that were on a wait list. I'm not 100% on that, but I think that's how it worked. But people that had already been registered. But you have to have somebody who, younger, who's a little bit more savvy. If you're an older person, you don't know how to do that. I've talked to a lot of people, they have their grandkids, register them or reach out. And it seems like it's harder for people that don't have access. Yeah. How are they going to reach those people?
Well, that's where the CBOs can come in, because the May Center, for example, has access to thousands of senior Cambodians. And so when we put the word out, there's a mobile clinic coming on the 22nd. We would have hundreds of people that we could sign up. Again, there's been no funding provided to the CBOs to do that kind of outreach. And it's extensive. Just signing people up on the website takes time. So I know one Cambodian resident, Charles Song, who is very active in the community, himself signed up 50 people. I mean, all that's very time consuming, and like the directors have many things to do. We need to be hiring staff whose function it is to sign people up, if that's the way we're going to do it. Or it needs to be a second door or a third door for people that aren't literate, of which many people in the Cambodian community are not, and in the Black community as well, so that they have a chance to get the vaccination. That's, those are things that we know about these communities that should have been built into the rollout.
And Professor Norman, specifically with the challenge of the mistrust in government, what do you think are some ways we could reach out to the Black community to regain some of that trust? Or
you got unmute, Alex.
Thanks. Well, one way would be to build inequity from the beginning rather than as an afterthought. If you know that there is likely to be skepticism for a specific population, whether it's a Cambodian population or whether it's the African American population or a Latino population, you would have information that you could get to them in the language that they can understand from people who are credible to them. So that means then that that would be a rollout in which information could be provided either by staff that are African American staff,
Maybe
or
churches
maybe
partnering.
a mobile unit,
Yeah.
a mobile unit that caters specifically to the African American community, so that you don't have the one mobile unit for the Latinos in 1 month. The same mobile unit has to travel now to the Cambodian population, and that same mobile unit has to go to a Latino population. There ought to be several mobile units. That's one. That is to have education as a center, with equity as the screen through which you view the vaccine rollout. I think you also need to do what they did at Kedron. What they did was that they had people who were familiar to the community people giving the shots, because the suspicion is still there. I'm sure the suspicion is there with the Cambodian community in the same way that it's there with the African American community.
Or even with the Latino community, with a lot of immigrants and undocumented
A lot of
immigrants.
immigrants in the Latino community, and the issue is the same. So it seems to me that if we look at equity, we will look at what is equitable for the Latino community, which is likely to be different from what is equitable for the Cambodian community, which is likely to be different from what is equitable with the African American community. And instead, what we seem to have is a one size fits all, using zip code data. Now, the health department insists on using zip code as the unit of analysis for its data. Zip codes were designed to deliver mail. They were not designed for demographers or statisticians to analyze data to give information about communities. Census tracts were designed for that. So that if we use census tracts as a unit of analysis rather than zip codes, it would tell us more about who is missing, where they are, and what the demographics look like. So there are a variety of things that we can do, but one of the things that we have to do is use equity as the screen rather than the afterthought. And it would seem that in this situation, the fact that this committee has been meeting for a whole month without even bringing in the Cambodian community tells you that equity, insofar as Cambodians are concerned, is an afterthought with the health department.
And Professor, you did some interesting work under group Rethinking Greater Long Beach that I wanted to touch on because I thought it was fascinating. Just looking at the life expectancy by zip code. I think you did under census tract and then under the zip code. But what was it again? There was like a 10 to 15 year difference in life expectancy for residents in North Long Beach, Central Long Beach compared to East Long Beach. Can you talk a little bit more about that? I just thought it was interesting for people to know the huge disparities just in life expectancy in Long Beach, where you live.
Yeah, well, the zip codes, the health department likes to say the zip codes can determine your life expectancy. And it's true. Census tracts can do it even better, though. But basically, what it means is that we did quintiles, so that we divided the socioeconomic groups into 5 groups, high and to low, with a median quintile group for those who were not poor, but not wealthy either. And what we basically found was that in the high socioeconomic economic areas, people, even if they were older, they were healthier.
Yeah.
And their life expectancy was longer. So that if you know that at the outset, then you, even though 90803 may very well have the largest
Sure.
of older people, they're going to be older, healthy people, as opposed to 90805 that will have Latinos or African Americans whose life expectancy will be less, and they will be less healthy. So
That was surprising to me, just to see 90803 you bring up had the highest rate of vaccines in all of the city, but one of the lowest, one of the highest life expectancy rates, and then one of the lowest death rates for COVID. I think it was when you took out nursing homes, it was not like about a dozen people had died from COVID in that zip code, but yet it had the highest rate of vaccines. So it's difficult to, were you surprised by some of the inequities that you've seen just with this vaccine rollout?
not really, because if you understand that racism is built into the system, so is privilege. And so the assumption has to be that the system was, for whom the system was designed, is for whom the system benefits. So if the system was not designed for African Americans, Latinos, or Cambodians, it's not going to benefit them. It's going to benefit who it was designed for. And the system was really designed for whites. So no, I'm not at all surprised at that.
How do we, and again, we've touched on this, and I know it's a difficult question, but how do we work on changing this? You know, how do we move forward with this? It seems with this pandemic, it's highlighted, you know, systemic, long time issues, and where do we go moving forward? What do you guys think?
Well, I would say that first thing has to be an acknowledgement of these problems. You know, when, you know, we had to bring him to the city council special meeting with no data whatsoever because we didn't have any. And how is it that, you know, this little band of 3 people can figure out that there are major problems in the delivery system without any statistics, but the city who has access to all the data can't do the same? So we need to stop, you know, saying it's okay to wake up one morning and say, oh, gee, we have 15,000 Cambodians. I bet we better include them in this rollout and start building them in at the beginning. That would be a good start. And then for this particular rollout, we have to acknowledge, the city has to acknowledge its failures in the initial rollout, which it's trying to do without any sort of apology or even mention that it didn't do a very good job on the first go round. But as long as we keep ignoring that there's an elephant in the room and keep doing the same old thing, all this data is predictable.
Well, for me, I think for the process itself, you know, the word equity has been thrown around like a key phrase. And so if we look at the process itself as the vaccine rolled out and say, well, what is Long Beach made out of? Who lives here? What are the needs of the community? And have a roster of, these are the Cambodian organizations, these are the Filipinos, African Americans. When we're reaching a situation like this, like the pandemic and the vaccine rolled out, we should be able to have everyone on a roster and shoot out a massive email to everyone to have them engage in the beginning and say, what are the challenges in each community from the get-go, from the start. In addition, there's a relationship that needs to be built between the city, different various departments, with the people, with the organizations. So you would know that there is a Cambodian FQHC. You would know that contacting the Cambodian doctors would be an effective way to say, hey, can you contact your thousands and thousands of patients and educate them about the vaccine rollout, about COVID? And in addition, it goes to the funding. Thirdly, is the funding, either by the city or by the funders themselves. You can't constantly keep funding a white organization hoping to reach the Cambodian organization. It doesn't work that way. There's no cultural competency when you're building a system of funding based on who has been here for the last 40, 50 years, who have more connections, versus how do we create an equity for these organizations that are serving specialized communities. And that would have been a good start for us to pave a way towards a more equitable process.
Right. Well,
you know, what I see is really I call it an axis of arrogance. It's the city has a council, it has a manager, and it has community. And those organizations that the city deals with deal with the city on the city's terms. And that means to go along, get along. And the assumption is that the city knows best what is good for people without even contacting the people, until it turns out that they don't know what's best, and then they contact the people. Now that's the arrogance that that Mark is saying goes along with not even apologizing for the fact that you exclude someone. It seems to me that we really need to have conversation about this, some honest conversation about this with the city, about how can you really establish a relationship with people all year long, rather than waiting until a calamity happens and then you go to your regular cast of characters who, while they may be providing good service, they're not really connected to the population that you need. So I think that we have to dismiss ourselves of that arrogant attitude that the city knows best and accept the fact they really don't know, which then allows them to use the intelligence of other people. And Long Beach doesn't do that very well. It doesn't accept information and knowledge from, in quotes, others. It has a not invented here syndrome. If it's not thought of in Long Beach, it doesn't fly. If somebody else brings it in, it's not accepted.
Okay, well, interesting. Well, thank you guys. We're out of time here, but I appreciate it. And hopefully, you know, with Laura on the task force now, there will be some important dialogue, and the city will, you know, move forward and make some changes. So important conversation for sure. Great. And thank you again so much for joining me. Appreciate it. And if you guys have any more questions, you can put it in Facebook comments, and we'll try to get them answered a little bit later. And thanks, everybody. Appreciate it.
Thank you for having us.
Thank you.